Hello, and welcome back to Past PEBC with me. Today, we are doing another chapter from Therapeutic Choices, Depression. I know while studying this chapter, you might get one, but we are PEBC warriors, so get ready. What is depression really? Depression isn't just one disease. In fact, there are a few main types. Major depressive disorder, MDD. This is what most people mean when they say clinical depression. It's intense, it lasts at least 2 weeks, and it doesn't just pass if you cheer up. Dysthymic disorder. Think of this as depression's quieter, long-term cousin. It hangs around for years, not always severe, but it's always there. And then there's depressive disorder not otherwise specified, basically when symptoms are real but don't fit neatly into the MDD checklist. And here's a pharmacy reality check: not all low mood is depression. Sometimes it's bipolar disorder in disguise, sometimes it's due to alcohol or a medication, or even a medical condition like hypothyroidism. Why does that matter? Because if you miss bipolar disorder and start an antidepressant, you can actually make things worse. How we diagnose it? For MDD, there's a rule. You need at least 5 symptoms for at least 2 weeks. And one of them has to be either low mood or loss of interest in things you normally enjoy. Other symptoms can be changes in weight, sleep problems, fatigue, feeling worthless, trouble concentrating, or thoughts of death. Pharmacy tip. In practice, doctors often start with 2 quick screening questions. 1. Have you felt down, depressed, or hopeless in the last month? 2. Have you lost interest or pleasure in things you normally enjoy? If someone says yes to both, that's a big red flag for further evaluation. Goals of treatment. This is more than just making someone feel better. We aim to get complete remission, not just improvement, but prevent suicide. Help the person get back to their life, their job, their relationships, and prevent future episodes. First step, non-drug options. Now here's something people often underestimate: psychotherapy works. Cognitive behavioral therapy, CBT, helps patients recognize and change negative thought patterns. Interpersonal therapy, IPT, focuses on relationships and life changes that might trigger depression. For mild to moderate depression, these can work just as well as medication. For chronic depression, a special CBT approach called PEBC works even better when combined with medication. And let's not forget psychoeducation, telling patients exactly what to expect. Take your medication every day, give it 2 to 4 weeks to work, and don't stop just because you feel better. It sounds simple, but it massively improves adherence. Pharmacologic choices. Let's talk meds. Alright, let's get into the pharmacy meat of this chapter. Pill first line for most people? SSRIs. Why? They're effective for about 60 to 70% of patients. They're generally well tolerated. And they're easy to dose. But here's the catch. Side effects can include nausea, headache, dizziness, which often fade, and sexual dysfunction, which often doesn't. Around 40% of patients experience this, and unless you ask, they might not tell you. Examples in Canada: citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline. Escitalopram may have slightly better efficacy in some studies. Paroxetine has the worst withdrawal symptoms if stopped suddenly. Other drug classes. Bupropion boosts norepinephrine and dopamine. Energizing, less sexual dysfunction, also helps with smoking cessation. Avoid in seizure disorders or eating disorders. Mirtazapine, great for patients with poor sleep and low appetite. It causes sedation and weight gain. Trazodone, technically an antidepressant, but at low doses, 50 to 100 milligrams, it's mostly used for insomnia. SNRIs, venlafaxine and duloxetine. Venlafaxine can be more effective than SSRIs at higher doses, but watch for blood pressure increases. Duloxetine helps with pain as well. TCAs, like amitriptyline and nortriptyline. Effective, but lots of side effects and dangerous in overdose. Usually not first choice unless other options fail or there's a specific reason, like chronic pain. MAOIs, like moclobemide, phenelzyne, tranylcypromine. Moclobemide is safer with fewer food restrictions. Irreversible MAOIs are a last resort for resistant depression because of strict dietary rules and interactions. When first line doesn't work, we call this treatment-resistant depression. Options include switching to another antidepressant, sometimes within the same class, sometimes to a different class. Augmenting, adding lithium, or in some cases, an antipsychotic like quetiapine or olanzapine. Combination therapy, pairing medication with CBT or IPT. And in severe cases, ECT, which works in up to 90% of patients, but relapse can happen if no maintenance plan is in place. How long to treat? Here's what the guidelines say. After the first episode, treat for at least 1 year. After 2 or more episodes, treat for 2 years or longer. Always taper slowly, especially with paroxetine or venlafaxine, to avoid withdrawal symptoms like dizziness, nausea, or brain zaps. Special populations. Pregnancy. If possible, start with therapy like IPT. If medication is needed, fluoxetine has the most evidence. Reduce dose near delivery to lower newborn withdrawal risk. Postpartum depression. For breastfeeding mothers, safest SSRIs are citalopram, paroxetine, or sertraline. Mild cases, therapy first. Severe cases, combined therapy plus meds. Bipolar disorder. Always screen before starting an antidepressant. Missing mania history can be dangerous. Bipolar depression needs a mood stabilizer in the mix. Key exam pearls. SSRIs equals first line for most patients. Bupropion equals low sexual side effects, but avoid in seizure/eating disorders. Moclobemide equals MAOI without tyramine restrictions. A lithium equals gold standard augmentation for resistant depression. ECT equals highest response rate. Always ask about past mania before starting antidepressants. So that's depression, not just a list of drugs, but a condition that changes lives. For your PEBC prep, remember, know the diagnostic criteria, know your first-line treatments, and never forget the human side. Because in the real world, behind every prescription, there's a person hoping for their life back. So that's all for today. Thank you for watching, and don't forget to like, share, and subscribe the channel. The next video will come soon for the MCQ practice. Till then, take care. Bye-bye.